particularly important. But it was when George H.W. Bush was vice president running for president, he came to the NIH and had the opportunity to show him around and really brief him very, very intensively about this new emerging outbreak that people were now starting to pay attention to. So George H.W. Bush really took on HIV/AIDS, and the budget of the NIH went very, very, very high. And here's a picture of George H.W. Bush and Barbara Bush in the solarium, and those people who are dressed around him are my patients who got all dressed up to talk to the President of the United States and his wife, Barbara Bush. And here he is listening very attentively, and I'm sitting right next to him, and one of my prized patients is between him and Barbara Bush, and he really did get it. But he got it at a time when, remember, we missed several years before of realizing how extraordinary this outbreak was going to be. And the budget for the NIH comparably went up. If you look at the time that George H.W. Bush became president and the time that he left the presidency, we had a dramatic increase in the HIV/AIDS budget, which led to extraordinary advances in every one of the areas on these yellow boxes. I could spend the entire 25 minutes, half hour, talking about each and every one of these individually, but the one that was the most important, and it gets to one of the things that was said during the panel with Ron and with Amy about the scientific aspects of the investments in science, because it was the investment in science that led to treatments which completely turned around what was one of the most depressing things that we possibly could have faced, a disease that was essentially 100% fatal. So here again is a picture of me making rounds on our ward in the early 80s, and the reason I show it is because at that time we had no therapy. This was 1982-83. And the only thing we were doing was putting Band-Aids on hemorrhages, and people were dying. But it was the scientific endeavor, the investment, ultimately in billions of dollars, that led to the drugs that we have now that have completely turned around the course of an HIV-infected individual, such that the median survival in this picture was about a year to 15 months. Today, in the same room that I see patients, the median survival now is an additional 50+ years, which is one of the most extraordinary scientific advances that has been made in response to a new outbreak. So one of the things we did back then, and I did this with my colleague Greg Folkers in my office, we put together a commentary in JAMA saying, you know, we've been quite successful with HIV/AIDS. Perhaps there are implications for other infectious diseases of global health importance. And what are the lessons that we learned from HIV? One, you have to commit substantial financial and human resources. These things don't get addressed spontaneously by themselves. You have to enlist the best and the brightest investigators in both basic and clinical research. You have to involve the community, be it the gay community in the United States, or the community in Africa and West Africa when we dealt with Ebola, or the people in South America when we're dealing with Zika. You have to have cross-sector collaboration. You can't do it alone. The CDC can't do it alone. The NIH can't do it alone. You do it with all of us, with industry, with global organizations, with philanthropy and NGOs, and you gotta get the leaders and the policymakers involved. Those are the principles we learned, and we applied them. So from an NIH perspective, and I have to take that because that's where I'm coming from, these are the things that we get involved with: basic and clinical research, genomics, expansion of research capacity, like we did in West Africa and Liberia, the way the CDC did in Sierra Leone, the way INSERM did in Guinea, ultimately to develop countermeasures. So let's get back to my map now and take a look at it. I mentioned that there was also the trickling of dengue in the Americas, because remember, dengue is an Asian African disease, and it came in under the radar screen, but now we're really addressing it. And so when you look at dengue, right now we have our sights on dengue. They're very much the same way as we're doing with Zika. And actually, this is a release from just this spring. in which we now have an experimental stage, a phase 3 clinical trial. We have an approved dengue vaccine that we need to do better on because it's only about 60-some-odd% effective. So we really want to get one that's up in the 85 and 90%. So that was George H.W. Bush. Then things started to heat up a bit when we got to President Clinton because he had to deal with HIV. It wasn't going away. But now we had some other things. West Nile, H5N1, antibiotic resistance. We go back to the same paradigm of the things you need to do. You need to do basic research. The CDC does public health. The WHO does what they do. And you wind up with countermeasures. And let me take a look with you at some of the things we had to deal with and some of the briefings of those 200-plus briefings that we had to do. One was West Nile. West Nile is re-emerging. It isn't new. It was in Africa and the Middle East likely for hundreds of years. Then either a mosquito, a bird, or a person got on a plane in Israel and landed at Kennedy Airport, and then, boom, we now have West Nile, which is endemic in the United States. So what are we going to do about it? We're going to develop countermeasures, such as vaccines. Now, it's very interesting. When we first started to develop a West Nile vaccine, we had a successful vaccine. It was safe. It induced a good immune response. We couldn't find a company to partner with us to develop it in an advanced way. That is not the case now with Zika, since there are a number of companies that are very interested in that. Then there's the issue of antimicrobial resistance, which we have gotten very deeply involved with, up to and including the current president who gave an executive order. So I don't want to jump ahead of myself, but these are not things that just stay with one administration. They spill over into the other. So we first in earnest started to see it back then, so we really addressed it, as we've done in so many other things. Then came George W. Bush. Again, HIV/AIDS was still prominent, but he had to deal with something that was really brand new here: anthrax, the beginning of H5N1, and SARS. Now, when you talk about presidents worrying that when they get into office, there's going to be something they have to deal with, some health issue that's going to be very disconcerting, well, it was a double whammy for George W. Bush, because not only did we have the terrible events of 9/11, but juxtaposed in the fall, in October, right after the 9/11 issues, we had the anthrax attacks. And then all of a sudden, a new outbreak that a president and the departments had to deal with was bioterrorism. And in fact, this is one of the articles that we wrote back then 15 years ago, Cliff Lane and John LaMontagne and I, in Nature Medicine, about bioterrorism and the kinds of things we need to do to prepare for bioterrorism. The country took this very seriously. There were strategic plans for the Category A agents, namely agents that we knew had been stockpiled by the Soviet Union before the fall of the Iron Curtain. Those were smallpox, anthrax, botulism. So I had the opportunity of dealing very closely with President George W. Bush and his staff in dealing with how we're going to address bioterrorism. And I had a very interesting experience, which I'll always treasure. We were going up to Pittsburgh together with the president, with D.A. Henderson, with Secretary Thompson and others, to look at a new facility for modeling the possibility of a bioterror attack. So I had the privilege of being on Air Force One, and the president called me up to his compartment and said, "Tony, what scares you most about potential microbial attacks?" And he was talking about a terrorist. And I told him, I said, "Mr. President, I worry more about the natural occurrence of an influenza pandemic and the ongoing plague of HIV than I do about a bioterror attack." That doesn't mean you want to diminish a bioterror attack, but it does mean that you have to pay attention to the natural causes. And with regard to HIV, in his presidency, as we all know, the president did something that is historic. He established PEPFAR in his State of the Union address in January of 2003 and announced a program which initially was $15 billion to prevent 7 million HIV infections, treat 2 million HIV-infected individuals, and care for 10 million, which turns out now unequivocally to be the most important global health endeavor that has ever been established in history with regard to any single disease. Now, getting back to nature being a bioterrorist, all of a sudden, everybody started to notice that, and the first hint we got about that, and this was still during the George W. Bush administration, was bird flu, H5N1. It emerged in 4 Asian countries. It then jumped into humans in a very ineffective way. Bill Steiger's up there. He and I took a trip to Southeast Asia with Secretary Leavitt to take a look at what was going on there. And the administration took this very seriously. They invested over $7 billion to prepare us for bird flu. So just the way you had the bioterror strategic plan, all of a sudden we had a pandemic influenza strategic plan, which is actually in effect right now. We still work through that plan. The CDC, the FDA, the NIH, we all use that plan. And again, getting back to the things that we did with the diagnostics, the therapeutics, we started to develop a vaccine. And we preemptively made a vaccine for H5N1, and we put it in the strategic national stockpile, the same way as we have one for H7N9. We haven't had to use it yet, but the idea of having something ready to go originated way back during the H5N1 days. But we really decided we needed to do better with our technology. So we advanced from egg-based to cell-based to finally recombinant DNA technologies. And we're continuing to develop better vaccine platforms. So if that wasn't enough, then SARS came along. Now the thing about SARS really scared us because it came on and it came on very fulminantly. It started off in China, went to Hong Kong. You all know the story. It's an epidemiologist's delight. I mean, if you want to specialize in epidemiology, you just got to read this, and if you have any children you want them to go into epidemiology, tell them the SARS story. They'll all go into epidemiology. And it was someone who went to a hotel in Hong Kong. 19 people in that hotel got on planes and went to different parts of the world. And then we had the SARS outbreak, 8,000 cases, almost 800 deaths. Not only was it a public health issue, it was an economic issue. This is a picture of a near-empty flight from Hong Kong to Beijing in May 2003. It really put everything to a halt economically, including in Canada, because Canada had a big problem. So what did we do? Right then again, we jumped on with new technologies, because now we have rapid sequencing. You don't have to grow the virus. You can rapidly sequence it. And we wound up developing a SARS vaccine that we, again, never had to use. And the reason we didn't have to use it, because the public health measures completely put the lid on it. So here's an example of public health measures that are antiquated, if you want to call it that, working perfectly in stopping an outbreak. So then we get to the present time. A lot of headaches for this administration with regard to outbreaks. I mean, they had more than their share. There was the H1N1 pandemic right soon after the president came in. Now, remember, I know everybody in this audience is sophisticated about that. You see his presidency, 2009 to 2017. What happened in 2009 as soon as he walked in the office? The H1N1 2009 pandemic